Welcome to our webinar titled CCUS, Impact for MDS Patients and Research. Why does this matter to me? Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generosity of our corporate sponsors, Amgen, Apellis, Tahoe Oncology, Alexion, and Merck, and the generous support of our patients, families, and caregivers for supporting the webinar today. I'd like to let everyone know about an opportunity to be able to meet and connect with other patients for support and to be able to share experiences. Each month, we host virtual support groups. Our support groups are led by patients and caregivers, just like you. All of the groups are posted on our website. Once you register for the group of your choice, you do receive a confirmation email. And as part of that email, there's information about how to join the group that you've selected. You can find out more information about the support groups at aamds.org. Now let's get to the webinar. Immediately following the presentation, there will be a question and answer session. If you are participating and you'd like to submit a question or a comment, please do so by opening the Q&A icon in the engagement panel on your right. To submit a question or comment, just type in the question and comment in the small text box window. When you finish typing, just hit enter. We'll do our best to get to everyone's questions today. When you are asking questions, I do ask that you do two things to help us manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our experts today cannot answer any specific questions related to your personal health care. We're very pleased today to have two specialists, Kelly Bolton and Dr. Eytan Stein. Dr. Bolton is a physician scientist with a background in medical oncology and genetic epidemiology. She's an assistant professor in the Department of Medicine of Oncology section of the bone marrow transplantation and leukemia at Washington University in St. Louis, Missouri. The focus of her research is regarding the interplay between inherited genetic variation, environmental factors, and acquired mutations in the shaping of the earliest stages of carcinogenesis. Dr. Stein is the chief of the Leukemia Service and the Division of Hematological Malignancies, an associate attending physician, clinical investigator, and the director of the program Drug Development in Leukemia at Memorial Sloan Kettering in New York City. He specializes in caring for people with acute and chronic leukemias, myelodysplastic syndromes, and myeloproliferative neoplasms. As an active clinical researcher, he works to develop new and innovative approaches to treating acute myeloid leukemia. It's my pleasure to welcome Dr. Bolton and Dr. Stein.
Great. Should I go ahead and start on my presentation?
Please, thank you.
Great. Thank you for that introduction. So today we'll talk about clonal hematopoiesis, and I'll explain what that means, and a disease entity called clonal cytopenias of undetermined significance. And we'll also describe some recent work that we've been pursuing, both Dr. Stein and I, on trying to prevent patients with clonal hematopoiesis from developing myeloid malignancies. So first, just to put this in a broader context, we know from large-scale studies where we've done sequencing of tumors for many different types of tumors, colorectal cancer, gastric cancer, esophageal cancer, among others, that we understand that what causes cancer fundamentally is the development of new mutations or genetic changes in our bodies that accumulate and lead a cell to become more and more abnormal, and then eventually to become cancerous. And this progression, where a cell develops multiple mutations, can occur over many, many, many years, in some cases, decades. And sometimes we're lucky enough that we can actually detect the early stages of this multi-step process. So we can detect some of these early mutations that may or may not lead to cancer. And we can very easily actually do this in the blood. So when you develop a genetic change in a stem cell in your bone marrow, in the right cell, in the right gene at the right time, it can lead to that stem cell expanding, and that process is called clonal hematopoiesis. So it means that there's a clonal, or one cell is overrepresenting other cells in the normal process of whereby a stem cell in the bone marrow produces blood cells. And this occurrence of clonal hematopoiesis, which I'll be abbreviating CH from now on, is super common as we age. So we've shown that from kind of standard studies where you do genetic profiling of the blood of just normal, healthy people, as we reach middle age, a large proportion of individuals will have clonal hematopoiesis. And the way that you essentially can detect this is these genetic changes that are present at low fractions in the blood. So they're rare. They're not present in all of our blood cells. They're present in a subset. And as we age, this becomes increasingly common. So we know that age is the most important predictor of who will have clonal hematopoiesis, but there's other factors that my lab and other groups have shown are important in predicting who is going to have clonal hematopoiesis. These include things like smoking, exposure to chemotherapy for pre-existing cancers like breast cancer, or radiation therapy as treatment for cancers. And inherited factors can also contribute to the development of clonal hematopoiesis. And the types of mutations that we see that drive clonal hematopoiesis are really the same types of mutations that drive myeloid neoplasms, including myelodysplastic syndrome and acute myeloid leukemia. But there's a long, there's a really big spectrum of mutations that we see in clonal hematopoiesis. So if we were to sequence the blood of 1,000 people, we would see that most of the mutations would be in these common genes that are common drivers of myeloid malignancies. But you see a very long tail of other genes. And if you go far enough out, we see additional drivers that can be targeted with targeted therapies in AML, including genes like IDH1 and IDH2. And the reason why, as scientists and clinicians, there's a lot of interest now in clonal hematopoiesis is because clonal hematopoiesis is a big risk factor for the development of hematologic cancers, especially myeloid malignancies. So if you took someone with clonal hematopoiesis compared to someone without, their overall risk is about 10 times higher if you have clonal hematopoiesis compared to not having clonal hematopoiesis. And the reason why there's an increased risk is because, again, we think that clonal hematopoiesis represents potentially the first phase, the first step in this multi-step progression to eventually hematologic cancer. But one thing to really remember is that clonal hematopoiesis is very common in the general population. So if we were to do kind of standard tests, standard sequencing tests in a population of people around the age of 50, we would find clonal hematopoiesis in about 15% of individuals. But the vast majority of those people will never develop any type of hematologic cancer. So while clonal hematopoiesis is a precursor or a precancerous state that eventually might lead to hematologic cancers, it does not in any way guarantee that someone will develop cancers. So we've done a lot of work trying to understand, who with clonal hematopoiesis is at the highest risk of developing a hematologic cancer later. And so we understand that certain genes that drive clonal hematopoiesis are more high risk than others. There's other kind of mutational characteristics that we've identified that are important. But one of the factors that seems to be very important is the mutation type, including people with mutations in TP53, the gene TP53, or the genes IDH1 and IDH2. Another really important risk factor that we and others have shown is that blood count parameters can predict risk of someone developing hematologic cancer later. So while people might have normal blood counts, certain features of their blood counts seem like they can be used to risk stratify people for who is the highest risk of developing blood cancers later on. And a really important factor that I'll get into now is the presence of low blood counts. So people that have low blood counts have much higher risks than the general population of developing hematologic cancers. But there's a lot of different types and causes of low blood counts. And we know from large studies in older people that having low blood counts, this is also called cytopenias, is very common in the elderly. So for example, among people that are 85 years old, even almost a fourth of them might have a significantly low blood count parameter, like low levels of red blood cell counts. And the frequency of this just increases as we get older. And so if you were to take a group of people that had unexplained low blood counts and profile them for the presence of CH, you would find that a significant fraction of them actually have an undiagnosed hematologic malignancy. And there's different studies that have tried to estimate this using different populations with the varying frequency, but maybe around a third or a fourth might have an unexplained hematologic cancer, and the other might have other diagnoses. But about 25% will have clonal hematopoiesis, and so the presence of clonal hematopoiesis, so these mutations in your blood, plus cytopenias, is now actually a disease called CCUS. CCUS stands for clonal cytopenias of uncertain significance. And there's been a few long-term follow-up studies of people with CCUS. And from these clinical studies, we've realized that that calling this clonal cytopenias of uncertain significance might be a bit of poor labeling, because people with CCUS actually almost always progress to hematologic cancer. So for example, there was a group in Italy who, a clinic that sees people with CCUS, and they followed these individuals for over 10 years. And they had 154 patients And 95% of these individuals developed a hematologic cancer by 10 years of follow-up. And most of these hematologic cancers were myelodysplastic syndrome or acute myeloid leukemia, so myeloid neoplasms. So this is a very high risk population of people that probably, throughout their lifetime will develop hematologic cancer. And, if you look at people that have CCUS, the types of genetic changes or mutations that drive the disease are similar to those that drive AML or MDS. And similar to that, about 2 to 3% of patients with CCUS will have IDH1 or IDH2 mutations. So a question that we're really interested in understanding and trying to address is how we can prevent people that have CCUS from developing myeloid neoplasms. And we think this is a real opportunity to change the disease course of AML and MDS and really improve overall outcomes, because we know that CH is a precancerous state and can be detected potentially many years or even decades before someone goes on to develop AML or MDS. So that means that we have a good for many patients, extended period of time where we could identify these people and potentially intervene. And the other great opportunity here is that we know the types of people that have clonal hematopoiesis that are at the highest risk of progressing to AML or MDS. And as I was describing previously, these types of people are people that have, certain mutational features, like they have a TP53 mutation or an IDH1 or 2 mutation, and people that have low blood counts, so people that have CCUS. So this means that if we can find that, if we know about that high-risk population, perhaps we could even target those mutations to prevent these individuals from developing AML or MDS. But this type of study that we're proposing basically is a chemoprevention study. So a study where we're using a drug to prevent the development of cancer. But chemoprevention is really hard. And there's not honestly a lot of examples of this being successful in cancer. And the reason is because, first of all, anything that we do to people, that any intervention that we offer has to be very safe. So these patients that have CCUS don't have cancer, and so we need to make sure that anything we do, we can guarantee that this is going to be a safe treatment that won't harm them. And second, this has to be well tolerated, and it has to be easy for the person to participate in and to continue the treatment, because it's going to be given potentially long term. And the other barrier that's more logistic is just that because these trials tend to involve like rare populations, rare groups of people, and they need to occur over long periods of time, means that they're difficult to conduct and they can be quite expensive. But sorry, and so I'll end this now with this idea that we think we have an opportunity to try this, though, using IDH1 and IDH2 inhibitors, and Dr. Stein will explain why we think this is the case next.
Okay, thanks so much. Let me just share my slides. Second. Okay, can you guys see my slides? Or Kelly, can you see my slides okay?
Yes, and maybe yeah, there you go. Yep.
Okay. So I'm gonna briefly talk about sort of what Kelly introduced, which is how we want to take current therapeutics that we have for patients with more advanced forms of myeloid malignancies like acute myeloid leukemia, and then try to use them in earlier lines of therapy to help prevent the development of myelodysplastic syndromes and subsequently prevent the development of acute myeloid leukemia. So I'm going to not show you all of these slides. I'm only going to show you some of these slides. And the first slide I want to show you is that when a slide from a completely different disease. And the reason I'm showing you this slide from this completely different disease, which is not myelodysplastic syndrome, but is called acute promyelocytic leukemia, is because really the dream of preventing and curing patients with myelodysplastic syndromes and acute myeloid leukemia is not something that we should think is going to be, 100 years in the future. We've actually already been able to cure one subset of acute myeloid leukemia, and this is a subset called acute promyelocytic leukemia, with a therapy that is very, very well tolerated and is actually not chemotherapy. I just want to show you, this is a survival curve for those of you who haven't seen these before. On the x-axis is time, and on the y-axis is the percent of patients that are alive. And what you can see on the left-hand side in panel A, in that blue line, is that patients who are treated with this novel regimen for this disease called acute promyelocytic leukemia really do exceptionally well. And you can see that their survival out past 5 years is just about 100%. And of course, the question becomes, how do we take this experience with acute promyelocytic leukemia and end up applying it to other myeloid malignancies and other subsets of myelodysplastic syndrome and acute myeloid leukemia? And one of the ways we want to do this is we want to do this by giving a therapy that is very well tolerated and can be given for patients with acute myeloid leukemia, thinking about, is there a way to give these to patients in earlier lines of therapy? And this therapy that I'm talking about is a therapy called IDH2 and IDH1 inhibitors. I'm just moving forward to the right slide. So IDH2 and IDH1 inhibitors are drugs that work exceptionally well to treat patients with myelodysplastic syndromes and acute myeloid leukemia that have IDH mutations. This is a study that we did in patients with newly diagnosed acute leukemia with IDH2 mutations. You can see that we treated in the second column, or the right-hand side column, you can see we treated 39 patients with acute myeloid leukemia who were newly diagnosed with an IDH2 mutation. The median age of the patients on this study was 77 years old. And then if you look at how these patients ended up doing, you can see that about 31% of the patients had a response. And of those, about 20% of patients went into a complete remission. So you take newly diagnosed patients with acute myeloid leukemia with an IDH2 mutation, you give them an IDH2 inhibitor, and 31% of those patients will end up responding. Now, what about if we move into an even earlier line of therapy, which is myelodysplastic syndromes? So like Kelly told you, the progression from a mutation to the development of clonal cytopenias of undetermined significance, to the development of a myelodysplastic syndrome, to the development of acute myeloid leukemia is really a stepwise process. Sometimes that stepwise process is very elongated and can happen over the course of years. Sometimes that stepwise process ends up being more contracted and can happen in a shorter period of time. So with these IDH inhibitors, which are very, very promising for patients with newly diagnosed AML, we ask the question, well, what if we take these drugs and instead of giving them to patients with AML, we move them into patients who have IDH mutated myelodysplastic syndromes, thereby sort of getting the patients with MDS to be reverse their disease and maybe even prevent it from progressing to acute myeloid leukemia. So this is a study we published 3 years ago, where of a large group of patients who were enrolled on a clinical trial for patients with IDH2 mutations, getting an IDH2 inhibitor, we picked out the 17 patients who had a myelodysplastic syndrome, and they were broken down into 10 patients who were in the dose escalation group and 7 patients who were in the dose expansion group. And when you look at the response rates for patients who had myelodysplastic syndrome with an IDH2 mutation, you can see that the overall response rate, and that's in the second column on the first line, was 53% when you gave IDH2 inhibitors to this patient population. And if you looked at the group of patients who had previously received the standard therapy for MDS, which is a hypomethylating agent, and then the patients ended up receiving this IDH2 inhibitor, almost 50% of those patients ended up having a response, which is actually quite dramatic. And the median overall survival was very good at 16.9 months. This is a small study. There have been larger studies that have been done that have sort of recapitulated this data. One thing I want to point out before we move on to this next part, which I'm going to talk about, is that actually there's a drug that is available for patients with myelodysplastic syndromes with an IDH1 mutation that's called ivosidenib. That drug recently got approval by the FDA for the treatment of MDS with an IDH1 mutation. Okay, so I just showed you how we're using IDH inhibitors for patients with newly diagnosed and relapsed and refractory myelodysplastic syndromes. But then we asked the question that Kelly brought up, and Kelly and I worked on this very closely together, really asking the question, well, is there a way to prevent clonal cytopenias of undetermined significance or clonal hematopoiesis from ever turning into a cancer-like condition or a cancerous condition? Can we prevent a patient from going from clonal cytopenia of undetermined significance over to myelodysplastic syndrome? And that would be I just want to highlight, that would be a dramatic advance in the treatment of myeloid malignancies. We have never, ever had a therapy that could prevent the progression of a precancerous condition into a cancerous condition when we're talking about the field of myeloid malignancies. And that's just what I asked in this question here. So this is a trial that is being done both at Memorial Sloan Kettering and at Washington University, where Kelly is. And the trial is done as follows. So Kelly, or Dr. Bolton, has really done an outstanding job of getting her part of the trial, which is the IDH1 part of the trial, off the ground into a virtual trial. I'll make a couple of comments and then Kelly can add on about this, because I think this is really, really exciting and really the future of clinical trials in the United States. So basically, for most clinical trials, if you want to enroll on the clinical trial, you can't be anywhere in the world or anywhere in the country. You have to go to where that clinical trial is open. So Memorial Sloan Kettering, if I have a patient who calls me and says, I want to be on a clinical trial for whatever disease, I have to call them back and say, that's great, but you should realize that if you're going to do that, and we'd love for you to do that, you're really going to have to move to New York City for the next month or two. What Dr. Bolton has been able to do is do a decentralized clinical trial. So you can see that a patient with an IDH1 mutant clonal cytopenia of undetermined significance can live anywhere in the United States. That patient is monitored and supported by their local oncologist. The study visits are done remotely in coordination with the regulatory team at Washington University. And any blood tests that need to be done for the trial are done through a mobile phlebotomy unit that comes to the patient's home. And the study drug is shipped to the patient's home as well. So Dr. Bolton has been able to do this very well with a clinical trial for IDH patients with clonal cytopenia of undetermined significance with an IDH1 mutation. We had an in-person trial at Memorial Sloan Kettering for patients with an IDH2 mutation. Sloan Kettering isn't as I would say not as nimble maybe as Washington University. And therefore, because Dr. Bolton has done such a great job with this, we're actually going to be shifting sort of the primary location of our IDH2 trial over to Washington University so that this can also, the IDH2 portion of the trial can also be a decentralized trial. And, the benefit of this trial is that, again, you can hopefully prevent people from progressing from a clonal cytopenia of undetermined significance over to myelodysplastic syndrome. But I think our real dream, and I think I speak for Dr. Bolton as well, is that one day we'll be able to look at the mutations a patient has when they have clonal hematopoiesis decipher which of those mutations are most likely to lead to the progression to a myelodysplastic syndrome and acute myeloid leukemia, and then have a well-tolerated, safe therapy that we can give to those patients that will actually prevent them from developing cancer. And I think if we can do that, then I actually think our careers will be complete. And then we can go off and be happy that we've done something good for the world in our short time on this planet. I don't know, Dr. Bolton, do you have any other comments about this trial?
Yeah, I think with COVID, there were a few examples of studies that were conducted in this way, using leveraging a lot of the virtual and kind of home-based care that developed during COVID. And so now there's good guidance from like government agencies about how to conduct these types of trials. And a big indication of them would be, that they're really great for rare conditions where it's hard to, recruit patients. But also the great thing about them is that it minimizes the financial burdens, the time burdens on patients to participate in clinical trials. So I think it's great, and hopefully we'll see more of these types of trials that are being conducted throughout different types of diseases.
Okay, I think we're ready for the questions, which is the funnest part of these webinars.
Great. Well, thank you both so much for the wonderful presentation. We have a few questions. Our question is, if you're diagnosed with CCUS and then diagnosed with MDS, is your MDS considered secondary?
Alec, that's you.
No, it wouldn't be considered second. So the definition of a secondary MDS usually is that, or a treatment related MDS, that's really what we think about when we think of, I guess, secondary MDS. It is where there was some type of, pre-existing cancer and the person got cytotoxic therapy that maybe then led to them getting MDS later. But CCUS isn't a cancer. It's a pre-cancer state. And because of that, it's not really considered, it would not fit in that definition of secondary MDS. But I mean, it's an interesting, I guess fundamentally, maybe what you're getting at might also be that, do people that go through this period of CCUS, is their MDS any different? Is it, less aggressive, more aggressive? And that we don't know. Could the length of the precancerous state be indicative of kind of the disease tempo or aggressiveness? But we don't know that yet. But that's a really interesting idea.
Thank you, Dr. Bolton. Our next question has a couple of parts. This is from a patient who says they were diagnosed with MDS 2 years ago. They'd like to know, is CCUS going to become part of any type of standard testing for the diagnosis of MDS? Does a diagnosis of CCUS impact treatment options that you may be offered? And 2, is there any way to know if you had CCUS before your diagnosis, and does that have any benefits for the medical community, knowing how many MDS patients may have had CCUS before their diagnosis? So sorry, that's a multi-part question.
Eytan, do you want to answer it, or?
Yeah, I'm trying to think of the right answer. Because it is a multi-part, a little bit of a complicated question. I mean, I guess I think of it, I think of it again as this continuum, right? That patients initially develop, or people initially will develop a mutation in their bone marrow that at some point will lead to lowering of the blood counts and changes in what their bone marrow looks like, that we would call it MDS. But because if you think of it as a progression on a continuum, the question is, when do you do the testing, right? So when you do the testing will influence whether what the patient had was ever previously called CCUS, right? So let's say I had 100 patients, and let's say you had 100. Let's say I randomly went out to York Avenue right now in New York City, and I gathered 100 patients off this 100 people off the street, and I did bone marrow biopsies on them every month for the next 10 years. I mean, obviously you could never do that, but this is sort of a thought experiment. So probably, let's say 2 of those patients are destined to develop MDS. Probably at some point, you might be able to catch them in all stages of evolution, where, you know, at some point you might call them C8, clonal hematopoiesis. Some point you might have called them CCUS, and then at some point you would call them MDS. But, you know, of course, that's not how the world works, right? The world works in a way that patients only show up to a doctor's office when a doctor detects something abnormal. And once a doctor detects something abnormal, that patient will either have CCUS because their blood counts are low, or at that point, they will already have MDS. In terms of detecting clonal hematopoiesis, the way that typically gets detected now, at least I think at WashU and at Memorial Sloan Kettering, is that patients are having genetic testing of their blood done for a different reason, in the context of having a different cancer, like breast cancer or lung cancer or colon cancer. And as part of the testing done for those diseases, their blood is also tested for genetic mutations. These genetic mutations are picked up, and even though the patient may not have any sort of blood count abnormality, they then get referred into a clonal hematopoiesis clinic so they can be followed over the course of time and counseled about any sort of cardiovascular issues that come up with clonal hematopoiesis. So that's not a really good. I sort of started rambling, so I apologize. So I'm going to turn it over to Kelly. Kelly, do you have anything else?
Maybe Eytan, like, so how many, when you see somebody with MDS, how often did they have, cytopenias for like a year or two before they were diagnosed, like where you can go back and just see? Isn't it the majority? Do you think?
It probably is the majority, right? It becomes a question of, did they have MDS back then, or did they have?
Yeah.
Right. And there's really no good way to know that.
Yeah. But I would guess that most people do pass through that phase of CCUS, right? But before they reach MDS, but it's a question of like, how long were they CCUS for 10 years?
Yeah.
Or was it like 5 years, or was it 5 months? Like,
right.
And that we don't, is not super well defined yet.
Right.
Thank you both for that. Our next question is, what is known about progression potential in patients with CCUS who only have one chromosomal abnormality but no somatic mutations?
It's a great question. I think it's even less well defined. I honestly, most of the studies that have looked at CCUS, they've defined CCUS as being like the presence of a not like you're saying a chromosomal, like a big. So there's different types of mutations, different types of genetic changes that cause cancer, right? There's like changes where it can be a big like deletion or insertion of a big part of your chromosome, and that's like a chromosomal abnormality. that you would detect on like karyotype. And then there's these, more discrete changes where it's like a very small genetic change. And usually the small genetic changes are how people define CCUS. But we do, now that we started this clinical trial, some of our patients that have CCUS, we also find that they do have chromosomal abnormalities. But we don't know how, like, if those features are more or less important in like predicting risk of progression for CCUS, but there have been really big studies, like there are these big like biobanks, like of where people have 500,000 people in the United Kingdom have signed up, and they've had their blood sequenced, and they're followed for like 10-15 years. And in those studies, so in these like healthy populations without low blood counts, these chromosomal abnormalities occur less frequently than clonal hematopoiesis driven by these like small mutations. They're present more like in 2 to 3% of people. But if you have one of these chromosomal abnormalities, it does put you at a high risk of relative risk of developing a hematologic cancer later. So presumably, if we like extrapolate that data, it would suggest that these chromosomal abnormalities also would influence your blood counts and could cause CCUS, and they could also be high risk forms of CCUS.
Thank you. Our next question is, what mutations in CCUS lead to MDS besides IDH1 and 2?
Yeah, so there've been a number of papers published about this. I think the one that we think about the most, and again, Dr. Bolton can correct me or add on if I'm wrong, is a mutation in a gene called P53. That is a particular mutation that seems to have a higher risk of progressing to myelodysplastic syndrome than other mutations that are found, such as mutations in genes like DNMT3A, which is one of the most common mutations that we see in clonal hematopoiesis and CCUS. Dr. Bolton, is there any other one that we should be mentioning?
No, I agree. Yeah.
Thank you for that answer. Our next question is, how often would someone who is diagnosed with CCUS need to have a bone marrow biopsy?
That's probably a little controversial. So I'll tell you what I do in clinical practice. I don't know if it's the right thing to do, and I'm not sure there are any guidelines on this yet. But I do a bone marrow biopsy at when I suspect a diagnosis. And then when I do a second bone marrow biopsy is really determined by what the patient's blood counts are doing. And that's because in general, there are some exceptions, but in general, the indication for treating both CCUS and myelodysplastic syndrome would be when the blood counts get to a certain low threshold. And the blood counts are sort of like the bellwether, they're the canary in the coal mine of what's going on in the bone marrow. So, if a patient is diagnosed with, sort of mild CCUS and the blood counts are relatively preserved, I wouldn't do another bone marrow biopsy till the blood counts might start dropping. Of course, what we're trying to do is trying to prevent those blood counts from dropping to begin with. And then, that would actually change things a little bit.
Yeah, I agree with that the indication is with blood counts. It's, of course, like for research purposes, it's very like interesting to, try to, we're trying to do that at WashU, enroll people on research protocols where we're doing more frequent monitoring. But but like Dr. Stein said, the real indication is changes in blood counts.
Thank you both for answering that question. Our next question is, are most hematologists aware of the diagnosis of CCUS? This person is in Canada. They just made that little note.
These are awesome questions.
Yeah, it's a good question. I mean, I think that at a lot, I mean, certainly Canadian doctors are as good as American doctors. So I'll say that in advance. I think certainly at large academic medical centers, everyone is aware of CCUS. It's sort of like any disease. If you go to a place that does a lot of it, they'll know more about it than a place that doesn't do a lot of it. In a community practice that primarily, large community practices, both in the United States and probably in Canada, they typically see many more solid tumor patients than patients with CCUS and myelodysplastic syndromes. So I suspect they know about it because if they're up to date on the literature, but in terms of the expertise of what do you do about it and what does it mean, they may or may not have that. I suspect that what your doctor would do if they don't feel comfortable or familiar with it is they usually would refer you to someone who is familiar with it to give them sort of advice about what to do.
Yeah, and maybe just to add to that, I don't know if you've noticed this, Eytan, but I feel like sometimes we'll get referrals for patients where the outside pathologist, they saw a mutation, they saw the patient had low blood counts, and they actually maybe imply in the report that the person has MDS or AML, but actually when we see them and our pathologists review it here or at MSK, they don't think the person meets criteria. Part of that though is just that part of the criteria for like MDS is dysplasia or like the number of kind of funky looking cells, and that's something that's like there's a lot of interpersonal variation in like quantifying that, so it can lead to disagreements about like whether it exists or not.
No, I totally agree with that. I mean, at some point there will be an AI program that will replace our ability to standardize these things, right?
Yeah,
it's sort of like it's doing radiology, honestly. So
yeah.
Thank you. Our next question is, what is the difference between ICUS and CCUS?
That I definitely am not answering. I don't know the answer to that. Kelly, what's the answer to that question?
You know the answer, but it's just so ICUS is like idiopathic cytopenia of uncertain significance, and so basically that means that they have cytopenia. A person has like low blood counts. They have cytopenias, but you don't know why, and you haven't found a detectable genetic change / mutation in their blood or bone marrow. So that group actually is that group of people seems to be lower risk for developing hematologic cancer later on than a CCUS population is. So that's in part why, like, when people have come to clinic, come to a doctor and they have low blood counts, we do a bone marrow biopsy. We usually actually include, for several reasons, we include the mutation testing. And it can be helpful in like talking to a patient about their prognosis, because that that CCUS is a higher risk state, and then ICUS is lower risk for later development of cancer.
Thank you. Our next question is there any genetic testing recommended in CCUS? And if so, what kind?
So typically the genetic testing is done as part of the evaluation for low blood counts typically. So that's sort of baked into the diagnosis of CCUS, is that you have genetic testing, your doctor, your oncologist, or whoever, hematologist, orders genetic testing because the blood counts are low. The genetic testing is done, it finds a mutation, and the presence of that mutation and the appearance of the bone marrow in a bone marrow biopsy, meaning it doesn't rise to the level of MDS, is what defines it as CCUS. If the question, again, I'll take a little bit of a tangent, but if the question is, should genetic testing be done because of a concern that this may be an inherited disorder, that that perhaps someone inherited this from a parent, and maybe they're worried that they're going to pass a specific genetic mutation on to their family member. There are certain genetic mutations and alterations that tend to be what are called germline, meaning they're inherited from a family member. Those are typically relatively easy to pick up on these genetic tests that are being done at the time to see if you have CCUS. So there are certain mutations, and there are certain patterns to how much of the mutation is present in the bone marrow that can help discern whether other family members might need genetic testing.
Thank you. Our last question is SF3B1 is a common low risk mutation. If blood counts continue to fall with this mutation, is it now classified as a blood cancer?
That's a great question. So, Eytan, I believe in the new ICC criteria, if you have an SF3B1 hotspot and you have cytopenias, isn't that, even if in the absence of dysplasia, doesn't that meet criteria for MDS now?
I believe it does, but I would have to go back and look. But I think what Dr. Bolton's getting at is that it used to be that to define someone as having MDS, you would have to have the easiest way to say is cells that looked funny under a microscope in your bone marrow. But there are newer classification schemas that are now saying you don't actually need to have funny looking cells if you have certain mutations. So the presence of certain mutations in and of themselves, even in the absence of funny looking cells, is enough to say you have a myelodysplastic syndrome, which you could argue whether it's a cancerous or precancerous condition, but is certainly a neoplasm, I guess, is the easiest way to say it. And but I think it's important to note that this becomes a little bit of a nomenclature issue, meaning like if we do a bone marrow biopsy on the questioner and we find whatever, like that's what you have, whatever we call it, right? Like we could say, you know, we could make up a name for it, but it wouldn't change what's in your bone marrow. So I think it's important not to get too hung up on what something is called. And maybe what's more important is what is whatever we call this, whether we call it MDS or whether we call it CCUS or whether we call it a funny looking bone marrow with an SF3B1 mutation. The more important thing is, what is the chances that this is going to affect my life and cause low blood counts that that might be life altering in some way, and does this need treatment right now?
Bill, thank you so much, Drs. Bolton and Stein, for sharing your time and your expertise with all of us today. This webinar will be available to watch today on the webinar platform, and it'll also be available on our website within just a few business days. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 40 years. This concludes our webinar.